Uh, I'm not sure as to how many of the postgraduates who have logged in uh, have a basic knowledge about the physics and biology which is involved with radiotherapy. Because unless there is a basic understanding of physics and biology, it's very difficult to understand how radiation works and how technology has improved over the last 25, 30 years. So if you see this first slide of mine, basically radiation has all its impact on the DNA of the cells. So there's something which we refer to as a sublethal damage. Then there's something called a potentially lethal damage. And then finally you have something called lethal damage, which is referred to as apoptosis. Now, so the biological effects of radiation are basically focused on breaking strands of the DNA, which can either be a single strand break or a double strand break. And if it is a single strand break, the cells are able to repair themselves, but double strand breaks usually are lethal, and the tumor cells cannot repair themselves. So uh, the DNA damage, which we are always talking about, is always repairable with a low radiation dose, and the relation is proportional. So these are the 5 R's of radiotherapy, which always you have to keep in mind. There's something called the response of a tumor. Whenever we treat a tumor, uh, you must be familiar with the term radiosensitivity. For example, by and large, most head and neck cancers are squamous cell carcinomas, which are very, very radiosensitive. So there is an inherent radiosensitivity. This is when you compare it to a different pathology like a sarcoma or an adenoid cystic carcinoma, etc. Then there is tumor cell repopulation. So even as we are giving the radiation over multiple sessions or multiple days, the tumor cells generally tend to repopulate themselves. The other focus is on what we refer to as redistribution. You must be familiar with the term cell cycle. So you have G2, M, S phase, and synthetic phase, etc. So it's the G2 and the M, which is the most sensitive phase of the cell cycle. So we have to make sure that the radiation is delivered in such a way that the cells are in the most sensitive phase of the cell cycle, which could be either G2 or M. And between fractions, so we give one fraction of radiation today, is the next fraction tomorrow. Now, even 24 hours actually is enough for these tumor cells to undergo what is called repair. So there is a repair of radiation-induced damage. And there is also a reoxygenation of the tumor tissues, which occurs between fractions. So one of the main aims of radiotherapy is to deliver a very precise dose of radiation to the tumor and trying to minimize damage as much as possible to the surrounding normal tissue. So this is where, as I go through, I'll try to focus on the basic concepts of what's happening with recent technology. So ultimately, it amounts to an eradication of the tumor with a large bit of the focus on improving the quality of life and prolongation of life. So when you look back, when you talk about recent advances, when I started my career almost 30 years ago, we were using what was called a cobalt 60 machine, which uses gamma rays which get emitted from a radioactive isotope, which is cobalt 60. And there are a lot of disadvantages when it comes to cobalt machines. But one thing you still have to remember and understand is that Cobalt 60s are still being manufactured. In fact, Canada is one of the biggest manufacturers of Cobalt 60 equipment worldwide. Cobalt 60 machines are still being sold to a lot of countries, especially developing countries. And even if you take the government sector in India, even a city as big as Chennai, which has always been a pioneer in healthcare, uh, all the government hospitals 4 government hospitals in Chennai were still using only a cobalt 60 machine till about 2 years ago. So the linear accelerators, or the LINAC, as we refer to, has come into the government sector hospitals only in the last 2 years. There's a there's a big difference. I mean, cobalt 60 machines are cheaper, LINACs are more expensive. One of the main disadvantages of cobalt 60 is that it uses a radioactive source. So as we all know, radioactive decay keeps happening, and the radioactive half life of the cobalt 60 is only about 5.25 years. So after about 5 years, the activity of the radioactive source comes down by almost half, and maybe at the end of 7 years or 8 years, you will have to uh, remove the old source and replace it with a new source, which again comes with a lot of expense, etc. While the LINAC doesn't use radioactive technology at all, it's all X-ray based. It's electrical and electronic. The other thing which has seen a lot of advances, but seems to be more of a dying skill in India, especially, is brachytherapy. And brachytherapy in the past, if you take the high volume centers like Cancer Institute in Adyar, Tata Memorial in Bombay, PGI Chandigarh, All India Institute of Medical Sciences, there was a large volume of brachytherapy which was being done, especially for head and neck. So ENT was one of the primary areas where brachytherapy has got a large role to play. Oral cavity cancers like tongue, buccal mucosa, floor of the mouth can be treated very well with brachytherapy. Then later on came brachytherapy for nasal cavity and nasopharyngeal tumors as well. So this is just to show, I mean, the latest equipment, which is the high dose rate uh, brachytherapy equipment, which we use to deliver intranasal radiotherapy for nasal cavity or nasopharyngeal carcinomas. So going back again to a little bit of biology, these are all the characteristics which I was earlier talking about, that malignant cells divide more frequently, they repair less efficiently when compared to a normal cell. And this is what ultimately points to what is called a quantitative difference in response to radiation. So, as I mentioned earlier, the tumor cell is more sensitive in the M and late G2. So, if a large radiation dose is given, and if the tumor cells are in the S phase, they are resistant. Therefore, a second dose would not be effective. So that is why there is a fraction interval between each fraction. So you allow these cells to reassort themselves into a more sensitive phase of the cell cycle, where the second dose would be more effective. So this is where the concept of fractionation came up. And if you go back to the olden days, we were talking about radical radiation, which involved about 60 gray. Uh, Commonly, all the head and neck tumors, squamous carcinomas of the ENT region, used to be given 60 gray in 30 fractions. So this is 5 fractions a week spread over 6 weeks. So which ultimately amounts to 30 fractions. And your fraction size each day, we were delivering about 2 gray. Now, today, when you talk about recent advances, you have something called hypofractionation, where the radiation dose given per day is more than 2 gray. So we give doses as high as 3 gray, 4 gray, 5 gray, 6 gray. Now, to give you an example, in the ENT region, vestibular schwannomas or acoustic schwannomas can be treated very well with hypofractionated radiotherapy. So you don't have to give, radiation or spread over 6 weeks. You can complete hypofractionated radiotherapy for an acoustic schwannoma in just 3 days. So what we do is we deliver 6 gray each day. So it is 6 gray into 3. So Monday, Tuesday, Wednesday, 3 days, treatment is over for an acoustic schwannoma. This is a good example in the head and neck region. So we use a similar kind of, we go to fraction sizes as high as 7 gray into 3, or sometimes we deliver 5 gray into 5, essentially saying that we don't do the conventional radiotherapy spread over 6 weeks. You are actually finishing radiotherapy in just a matter of 3 days or 5 days. Then there is another concept which is recently caught in, which is called hyperfractionation, which is giving 2 or 3 sessions of radiation each day. But then your radiation dose per fraction will be slightly less. For example, I may give 1.8 gray in the morning and again repeat 1 point gray in the evening with a gap of, let's say, about 6 to 8 hours. So in a day, actually, you're delivering about 3.6 gray, but then divided into two fractions. So that is something called hyperfractionation. It's not something which we very commonly practice when you compare with hypo. But there are a lot of institutions in various other parts of the world which do it within a controlled clinical trial. Then there is something called accelerated fractionation, where you increase the number of fractions given per day plus shorten the treatment time. So the overall treatment time also gets shortened. So that's called accelerated fractionation. And last of all, a slightly older technology, but we still do use it even today, which is split course, which we use more in the palliative situation, where we give one total dose of radiation, let's say spread over about 2 weeks. Then we give a gap of about 2 weeks, allowing for all the acute reactions to settle down, and then we continue radiation for another 2 weeks. So this is, I'll probably skip this slide. That chart is actually one of the controlled clinical trials that we are doing. Now, the other thing which one has to remember is the effect of oxygen on tumor cells. Now, most of the tumors that we see, even including what you commonly would see in the head and neck region, are not healthy tissue. I mean, they're all unhealthy with a lot of infection. There is, purulent, foul-smelling discharge sometimes. So there'll be a lot of hypoxic tumor areas. Now, these hypoxic tumor areas could be either because there could be a temporary vessel constriction by the mass, or the tumor itself would have just outgrown its blood supply and thereby leading to a capillary collapse. So hypoxia and the ensuing infection which happens are two negative factors when it comes to uh, the response of a tumor to radiation. So more the infection and more the hypoxic areas within a tumor, less likely that the tumor is going to respond very well. So we do, I mean, in the large locally advanced, loco-regionally advanced hypopharyngeal or oropharyngeal or even tongue carcinoma tongue cases, where you see large proliferative exophytic growths. We generally tend to see a lot of failures, radiation failures, and ultimately after a couple of months or maybe when there is a recurrence, patients have to go in for a salvage surgery. So there's a lot of focus on the hypoxia of the tumor cell. So this is where the role of radiosensitizers has come in, and there are a lot of compounds, chemicals which have been used as radiosensitizers. So you try to give something along with the radiation so that you make the tumor more responsive to radiotherapy. So as far as head and neck is concerned, these are broadly the classifications. I mean, radical radiation is what we do majority of the times. Then there's palliation. Then you must be familiar with a lot of neoadjuvant, especially in carcinoma of the nasopharynx, where we do neoadjuvant chemoradiation. And there's adjuvant chemoradiation for the post-operative cases. Just to give you an outline of the usual pre-radiotherapy assessments that we do, of course, histopathology is very important. The other very important area is the pre-radiotherapy dental assessment, especially when we are treating cancers of the oral cavity. All patients have to necessarily undergo a pre-radiotherapy dental evaluation, including an OPG X-ray of the mandible and maxilla, just to make sure that the there is no active infection. Because if there is an infection in the jaw, in the bone, it's probably better to do a dental extraction prior to commencing radiation rather than land up with a problem a couple of months after giving radiotherapy when the vascular supply to the bone is much less. And a dental extraction in those kind of situations may lead to even osteomyelitis. So talking about radiosensitizers, this is something which is, there's a lot of theory which is involved, which probably all of you as students can go into your textbooks or go into the internet and learn a lot about Cetuximab, which came in a big way about 15 years ago, but it's probably not being used very commonly today. We do use it for head and neck. We were using it quite a bit about 15 years ago, but somehow we have found that it's very expensive, and looking at the cost versus the benefit, we are using it less and less with the head and neck, but it's probably got a bigger role to play in colorectal malignancies. So it's a monoclonal antibody. It's an anti-EGFR. It works against the epidermal growth factor receptor, and essentially there is an inhibition of the EGFR signaling pathway, and this is what enhances the response to both chemo and radiation. So in head and neck cancer, especially for all of you who are in the ENT, it's basically approved under broadly under three headings. You can use it in combination with radiotherapy for most squamous cell locally or regionally advanced head and neck cancers. Or you can use it in combination with cisplatinum based chemotherapy with 5FU, even in the setting of a recurrent loco-regional or metastatic squamous cell cancer of the head and neck. And the third, which is probably again not very commonly practiced in India, but there are a lot of institutions in the US which are using it as a monotherapy for the treatment of recurrent or metastatic, just giving cetuximab alone for patients who progress after platinum-based treatment. And what we commonly, if at all we do use, and I'm using it less and less nowadays, but what we practice is when we give cetuximab concurrently with radiation, we do what is called a loading dose. The 400 milligrams. What is this? I got a message. NP Nair is requesting to annotate the share. Okay,
Decline.
Okay, yeah. So we give a loading dose on day one, and then a week later we start the radiation. And once the radiation starts, which is 5 days a week for, let us say, 6 weeks or 6.5 weeks, every week again, once in a week, again cetuximab is given. Yeah. The other radiosensitizer is cisplatin, which is probably, I would say, the crowd favorite. It is cheap, and if you personally ask me, I mean, we've been using cisplatin now for more than 3 decades, and probably the best results that we have achieved are with cisplatin, and it goes very well with concurrent radiation. We just give it at 40 milligram per meter square weekly once. There are people who use a 2 weekly cycle or a 3 weekly cycle where they're giving us slightly cisplatin once a week, make it a once in 2 weeks or a once in 3 weeks cycle. The only thing which you have to make sure with when we are giving cisplatin is that the fluid status of the patient is very critical, and patients should be well hydrated both before and after the drug administration. Hyperthermia, again, is something which has gone through a long cycle. In fact, Cancer Institute in Adyar used to have a hyperthermia equipment many years ago, which became redundant after a few years of use. And again, now there is a recent interest. Again, some companies have come back into the market with some very compact hyperthermia equipment. So basically, the principle being that tumors are more radiosensitive if their temperature is raised. So this is again, in addition to giving something like hyperbaric oxygen, you can try out hyperthermia. So the most common practice which we are following today is the concurrent chemo radiation. The only times where we do give induction chemotherapy is if we find very bulky, loco-regionally advanced, large, fixed neck node, etc. Those are the only situations where we ask our medical oncologists to give maybe a couple of cycles of induction chemotherapy and then start the concurrent chemo radiation. So, going on to external beam radiotherapy, we've come a long way from superficial ortho voltage, and currently what we are focusing on is megavoltage and the particle beam radiation, which is either using electrons, neutrons, protons, or carbon ions. So let me have a quick word about the linear accelerators. These are the equipment which we have been using for the last maybe about 25 years at least. And of course, technology keeps on changing. One of the main reasons why we prefer using this is because we don't see much of skin reactions when we use the linear accelerator. It's a more homogeneous dose distribution, and ultimately, one of the main focus is on better precision. Electrons again is a particle which comes out from the linear accelerator. And in the head and neck region, we commonly use electrons mainly to treat very superficial cancers in the head and neck, especially if we have to boost the radiation dose just to maybe for any residual neck nodes remaining at the end of radiotherapy. Proton is something which is absolutely new as far as India is concerned. Uh, it has a very limited application. It's not widely available. In fact, Apollo has pioneered the first proton center in our country. We opened the Apollo Proton Cancer Center in January 2018, and I'm also closely associated with it. And we have treated quite a few head and neck cancers using the proton equipment. I will probably, it's easier for you to probably understand something about protons maybe as I move on, where I've got a couple of pictures to show you as to how protons are advantageous compared to conventional X-rays. Brachytherapy, again, as I mentioned earlier, is something which we should be using more and more, especially for cancers of the tongue, buccal mucosa, and floor of mouth. But unfortunately, most new radiotherapy centers which are coming up don't seem to be focusing on, getting good brachytherapy equipment and installing them in the department. So these are the real recent advances that we are talking about. 3D conformal. Then we moved on to intensity modulated radiotherapy. And what we are practicing today more and more is stereotactic radiotherapy. So when we talk about stereotactic radiotherapy, it is so highly precise that immobilization of the head and neck region becomes very crucial. And these are the kind of immobilization devices which we are using today in the department. These are all custom made for each patient, so it fits only only that particular patient's. It is done on day one before we start the radiation, and once it is done, every day when the patient gets onto the couch, the mask has to be fixed, and only then the treatment actually starts. I won't go back into the fractionation again. So in this slide, I wanted to point out that earlier I had mentioned something about 60 gray conventional fractionation, 2 gray per day, 5 days a week for 6 weeks, which is what we practiced for many years. But today, for most cancers of the head and neck, whether it's oral cavity, oropharynx, larynx, salivary gland tumors, we have now taken the dose up to 70 gray. The dose per fraction, that is 2 gray per day, remains. The number of fractions, 5 fractions a week, remains. Only thing, the overall treatment instead of 6 weeks, sometimes now has become 7 weeks. But at the end of the day, we are able to deliver 70 gray, which is what we refer to as dose escalation. And this ultimately results in better local tumor control and longer disease-free survival. Now, the only way we could have achieved all this in delivering such a high dose of 70 gray is if we have high precision radiotherapy equipment with us. You cannot deliver 70 gray with the olden day technology. At the other end of the spectrum, we have the palliative radiotherapy. We are still using the sophisticated equipment which we have today. Only thing, the dose and fractionation alone changes. We generally don't trouble terminally ill patients or people with very bad disease to be visiting the hospital for 6 weeks or 7 weeks. We generally tend to cut down the number of fractions and the overall treatment time. So you could use any of these schemes. You could finish the treatment in 4 weeks. You could finish the treatment in just 5 days. You could finish the treatment in 2 weeks, etc. When it comes to post-operative radiotherapy, which is another very commonly used setting as far as ENT cases are concerned, it could be tongue, buccal mucosa, hypopharynx, larynx. Where do we give post-operative radiotherapy? The factors that we closely look into are the T stage, the depth of invasion, whether the histopathology showed multiple positive nodes or whether there was extracapsular spread, and the presence of either perineural invasion or lymphovascular invasion. And again, doses today, earlier we used to deliver only about 50 gray, but today with the high precision technology that we have again escalated even post-operative doses to about 60 to 66 gray. Re-radiation is again another emerging field in radiotherapy, which we used to seldom practice in the olden days. That is again because we did not have technology. Today, since we have intensity modulated radiotherapy and protons, especially for patients who can afford protons, re-radiation is probably one of the most strongest indications for taking up a patient for proton radiation. So when we started off with conventional, we used to use what is called a two-dimensional beam orientation. Then we moved on to image-based radiotherapy planning. So all patients underwent what is called a pre-radiotherapy planning CT scan or an MRI or a PET scan, and then you view the tumor basically from multiple angles, and basically design the fields and the computer plan accordingly. So we call it the 3D conformal. Then in the early 2000s, we started what is intensity modulated radiotherapy, IMRT. And if you look at this image on the right hand side, this is actually a magnified version of what you would see inside the head of the radiotherapy equipment. So these are all what you see as lines here are all what we call leaves, multi-leaf collimator. These are all extremely minute. I mean, this is a highly magnified image. So these multi-leaves actually keep moving continuously during the radiation treatment. And what happens is they conform to the shape of the tumor. Because no tumor is a perfect circle or a perfect square. So they viewed from different angles, tumors would be visualized as different shapes. So today the current technology is able to shape the radiation beam to the shape of the tumor. So ultimately what happens is, because you are able to achieve this, you are able to deliver less radiation to normal tissues, and thereby your complication rates are reduced. So this IMRT is ideal for tumors situated near the critical structures such as spinal cord, heart, and eyes. So these are all the treatment-related morbidity which we normally come across. And because we've got high precision technology with us, the amount of parotid salivary gland damage which we inflict has come down. The radiation-induced mucositis in the oral cavity is much less. The swallowing difficulty is also much less. Patients who undergo treatment on the linear accelerators have much less skin erythema and desquamation. The bone dose is reduced. You can intentionally reduce radiation going to the temporomandibular joint, and therefore the incidence of trismus has come down. And same way, as you go up towards the base of the skull, you have to be very careful in how much radiation you deliver to the optic nerve, the optic chiasm, the retina, etc. So these are all the kind of technological advancements which we have today. This is all on the computer. It's all part of our software, which is incorporated in our planning software. And we are able to instruct the computer not to deliver more than a certain amount of radiation to any of these organs. So this is another development which we have today. We have what we call VMAT, which is called volumetric modulated arc therapy. The basic principle is IMRT, but what happens is the machine is continuously revolving around the patient as the radiation is being delivered. So our treatment times on the machine have become much shorter. A conventional IMRT treatment on the machine each day may take about 10 to 12 minutes. But a patient who's undergoing a VMAT radiation probably doesn't have to lie down on the machine for more than about 5 to 6 minutes. 5 to 6 minutes. IGRT is the other terminology which you have to be aware of, which is image guided. So the current generation linear accelerators which are in the market and what we currently use in Apollo in Chennai also are all IGRT machines. So all these machines come with an inbuilt CT scanner. So every day when the patient comes for treatment, the setup and the precision is actually governed by the CT scanner, because every day the patient undergoes a scan on the machine, and it is matched with the planning scan which we do on the first day. So this way we are able to maintain the accuracy and precision to a very high degree. And we've also started using a lot of PET scans uh, to improve target volume coverage. If we can fuse the PET image onto our planning scan, then we are able to very accurately delineate our target volumes. And this is what, of course, Proton, which is the most conformal radiotherapy, and uh, I will probably show you a couple of images as I go on. CyberKnife is the other cutting edge technology which we again pioneered in the country. 2009 March, the first CyberKnife was installed at our center in Chennai. And this, as you see, is what I'm showing you on the scroller is a very compact linear accelerator, which has been mounted on a robot. So this is a KUKA robot, which is a very famous robot which is used in all the automobile factories like Mercedes-Benz and BMW for increasing their precision work. And the couch is actually a 4-dimensional or 6-dimensional couch. So if someone were to ask me where I would use CyberKnife in the head and neck region, uh, acoustic schwannomas, hypoglossal schwannomas, where we have started doing radiosurgery. As I mentioned earlier, we deliver a very high dose, something like 7 gray per fraction, and we just finish the treatment in just 3 days, or maximum it would be 5 days. So this is how we actually do the computer planning today. These are the most recent. If you look at this image here, we have actually contoured even the pharyngeal constrictors. And when we plan radiation, now if you look at this image, you will find that the radiation has actually encompassed the entire region which is supposed to get the radiation, including the pharyngeal constrictors. Well, today, let's say if I'm using proton technology, I can actually spare the pharyngeal constrictors but at the same time treat the lymph nodes and the primary, etc. So this goes a long way in reducing the dysphagia and even long-term swallowing disabilities which people may have. This is another example of how you can actually, again, this involves mastication and swallowing. So you can actually do, you can contour the masseter and pterygoid muscles, and then instruct the computer to deliver less radiation. So to quickly run you through how we go about the planning, there's something called a gross tumor volume, which is what we see on the planning scan. It could be CT, it could be MRI, it could be PET. Then the clinical target volume is an expansion of the GTV, where we feel there could be microscopic cells. Then we instruct the computer to give what is called a planning target volume, which takes care of any movement. Most organs, even in the head and neck region, like the larynx, the pharynx, even the tongue, tend to move during treatment. So we have to give that adequate amount of clearance. Then we contour all the organs at risk. Now, for example, let us say this is how a planning scan looks, and you have a tumor sitting here on the right side. So whatever is seen on the planning scan as the gross tumor volume is contoured by us, and we label it as GTV. And then we have to give a little bit of expansion on that for subclinical extension, because the area around the GTV will usually harbor microscopic tumor cells. So it could be an expansion of about 1 centimeter or 1.5 centimeters all around the GTV. And we label this blue volume as the CTV. And what you see here as yellow. Now, again, see what we've drawn here in blue is the regional nodal volumes which are at risk. And then we give what is called a planning target volume, which is the PTV, which takes care of any movement of the head or the movement of internal organs which may happen during each fraction of radiotherapy. So ultimately, this is how we complete the contouring on the planning software, and we assign a particular dose. We could say 50 gray to the lymph nodes. We would say the parotid salivary gland should not receive more than 26 gray. The spinal cord should not receive more than 45 gray, etc. So you're improving the precision, you're decreasing the normal tissue dose, but at the same time, we have the technology to escalate the tumor dose. So this is what I mentioned about 3D. When you view the tumor from different angles, the tumor assumes different shapes, and this is where the machine takes what is called a multi-leaf collimator. Now, in the 1970s, all this orange area, which is actually not tumor but normal tissue, would be getting quite a bit of radiation. While the moment we started shielding all these areas with a multi-leaf, you are able to conform the radiation much better to the shape of the tumor. So this is how the multi-leaf collimator looks inside. Now this is the head of the machine, and you are actually looking inside the head of the machine, and you see these multi-leaf collimators which are assuming the shape of the tumor. So we call it beam shaping, and these are fully automated. So the whole thing has become less labor intensive today. And ultimately, if you look at this, even IMRT can give you a very good plan compared to the olden day 3D. But look on the right side, what proton can do. Now, for example, let's say you take a tumor of the nasopharynx. There's a lot of scattered radiation. All these blue areas and green areas are the low dose radiation areas. So a lot of normal tissues actually get radiated when we use conventional X-rays. So you can see it in the coronal and the sagittal view as such. While if you use proton, you can see that you're able to conform the radiation much better. For example, this whole region of the brain actually doesn't get any radiation at all. While even in an IMRT plan, this blue area could probably look at about 10%. I mean, this is getting 100% of the radiation dose. The blue area is probably getting about 10%. So this is what we are able to achieve with protons today. This is another case of a paranasal sinus tumor where there is a large role for proton radiotherapy. Again, you see one whole half of the brain which has been spared of radiation with proton. when you compare with the conventional treatment. Uh, this picture again shows you, let us say we are treating carcinoma of the tongue or the carcinoma of the buccal mucosa. When we use conventional X-rays, we are able to get a reasonably good conformality of the dose around the tumor, but still it delivers about 30%. The green is about 30% of the radiation dose, and the blue is about 10%. So even the opposite side, for example, sometimes the parotid gland, etc., gets a lot of radiation. But today, using protons, we're able to completely spare the entire contralateral side of the skull. So this picture again shows you what a proton can achieve compared to a conventional radiation plan. Again, when we treat the lymph nodal regions of the neck, uh, this is again a comparison of a X-ray plan compared to a proton plan. Lot of oral cavity, tongue, which gets about 10 or 20% of radiation dose, which ultimately leads to a lot of radiation-induced mucositis, which you can avoid completely by using protons. In fact, if you see the submandibular salivary glands, which are located here, are almost being on the left side. Of course, it's very close to the tumor. So, but on the right side, you're almost completely sparing the submandibular gland. While here, when you use conventional plan, the submandibular salivary gland also gets the full dose of radiation. So these are all the various ways that we contour. Now, for example, this is a hypopharynx. So as I told you earlier, the inner line, the pink line, is the gross tumor. The red line is the clinical target volume to take care of microscopic cells, and then you draw the lymph node regions, etc. This is for a vocal cord cancer when you want to treat only the ipsilateral vocal cord. And this is one of the areas which we have started focusing on today, where when we are treating vocal cord cancers or laryngeal cancers, we are trying to decrease the dose going to the carotids. So you can actually use either protons or intensity modulated radiotherapy to also reduce the dose going to the thyroid gland, uh, because a large proportion of patients who undergo radiation for head and neck cancers, many a time during follow-up, if you do a thyroid function test, you will find that many of them have become hypothyroid, and they have large TSH values, and they have to go on replacement thyroxine. So this is where most of our focus is on today. When we use high precision radiation, we try to reduce dose to the thyroid, we try to reduce the dose to the cricopharyngeal inlet, we try to reduce dose to the thyroid cartilage, and there could be a small trade-off. When you try doing all this, the software delivers a slightly higher dose to the spinal cord, but neural tissue has got a large dose limit, and we really don't worry about spinal cord toxicity. So just to show you the computer plan which we generate for carotid sparing. Now this is a conventional treatment plan for a left side vocal cord. So you will find that this entire area gets almost about 60 to 70% of radiation. Both the carotids here, the ipsilateral carotid and the contralateral carotid, fall well within the field of radiation. While when you generate a carotid sparing plan, you can almost give very negligible dose to the contralateral carotid, and probably limit even dose to the ipsilateral carotid to maybe less than 30% of the 100% which is being delivered to the vocal cord. Now, one of the reasons why we've started doing carotid sparing IMRT is, again, vascular structures have a reasonably large radiation dose tolerance. Nothing happens to vascular structures with even a full course of radiation, even if you're going to deliver about 70 gray. The problem comes when a couple of years later, a patient comes with a recurrence, and let us say you're not able to offer the patient a salvage surgery, and you want to do a re-radiation for the patient. Then, unfortunately, if you have done primary radiation with this kind of plan, where both the carotids would have received the full dose, then re-radiation becomes an issue. So today, whenever patients can afford, we counsel them to go in for intensity modulated radiotherapy so that we spare the contralateral carotid at least fully and reduce the dose to the ipsilateral carotid. So, in the unlikely event that a patient comes with a recurrence in future, re-radiation can always be done with some amount of confidence. So again, this is a similar. This is another patient's computer plan where we are doing an ipsilateral vocal cord, sparing the contralateral carotid almost completely, and the ipsilateral carotid probably just gets about 30% of the radiation dose. So this is where, I mean, we actually play around a lot with our computers. I mean, these are all very highly sophisticated planning software technology that we have, and today we are able to escalate the dose to the primary gross tumor volume and maximize the or minimize the radiation doses going to spinal cord, carotids, etc. So I'm almost at the end. Probably I just have one more slide. These are all the other uses of radiotherapy in ENT. Not very common, but juvenile nasopharyngeal angiofibromas we do treat occasionally. Glomus jugular. Glomus jugular tumor or the carotid body tumor is not. It's not very common. At the same time, it's not rare. We do have a lot of experience in treating glomus jugular tumors. Keloids. Keloids are another area where we use a lot of particle beam radiation, like electrons. Uh, we primarily cannot treat a fully developed keloid, but post excision, especially the keloids which form in the ear lobe following ear piercing. Some uh, of course, it's very strange. I mean, the earlier days only women folk used to come to us with ear piercing uh, scars which have developed into keloids. But we today we see a number of men also who do ear piercing, and we are seeing a lot of keloids. So we ask the plastic surgeons to excise the keloid, and we take up the scar within 24 hours. Within 24 hours of excision, we deliver just 5 fractions of radiation to the scar. And this has an action on the fibroblasts and it prevents the keloid from recurring. So this is keloids are another large part of our practice today. So that's it. I think that's the proton machine that we inaugurated in 2018, and especially for you people being in the being ENT doctors, I think protons have a large role to play, uh, especially for nasopharyngeal and paranasal sinus tumors. I think protons have a lot of benefits. Uh, and when it comes to oral cavity, I would say if you have a buccal mucosa uh, yeah, or uh, or a carcinoma of the oropharynx, like base of tongue, probably protons have a role to play. Lesser role when you come down into the neck, when it comes to treating the hypopharynx or laryngopharynx. One of the main advantages of proton is, as I'd shown you earlier, the beam almost ends at a particular point. There is no exit dose at all. There's something called a Bragg peak, and the beam just ends. So you're able to get a highly conformal dose around the tumor, and probably in the long term, one of the two main advantages are: one, normal tissue radiation doses are reduced, so your complication rates are going to be much less. And secondly, since the regions which are getting very low doses of radiation are going to be very low, the development of second primary malignancies is reported to be much less in a patient who's undergone proton radiotherapy. Thank you very much. I hope I was able to cover most of the
Thank you, sir. That was really informative. I'm sure PGs had a lot of new topic, new take-home messages today. So there are few questions from the chat section, and meanwhile, I've also enabled the unmute option. Anybody who wishes to interact can directly unmute and speak with the speakers. So the questions, sir. First question was by Dr. Ashish Jain. What is the cost difference between proton therapy versus a linear accelerator versus the Cobalt 60?
Well, I mean, okay. I mean, we don't do we at least we are not using Cobalt 60s anymore. But I mean, even in even in one of the private centers where Cobalt 60 machines are still functioning, you can probably have a full 6 or 7 week course of radiation for a head and neck cancer for maybe about 50 to 60,000 rupees. While on the other hand, a good IMRT or an IGRT or a VMAT plan that I spoke to you earlier costs anywhere between IMRT in our hospital costs about 2.4 lakhs. IGRT, which is image guided radiotherapy, costs about 2.9 lakhs, and a VMAT or a rapid arc plan costs about 3.4 lakhs. While for the same patient, if you were to do a proton treatment, it will cost you anywhere between 25 to 30 lakhs.
Oh my God, that is too expensive. So yeah, next question. Sir, does the side effects of radiation like dysphagia and hyperpigmentation improve post radiation, or is it permanent?
See, I mean, most of it, I mean, at least 60 to 75% of reactions are all acute, and patients face it only during treatment. But there is bound to be, especially when it comes to dry mouth, for example, xerostomia. Yeah, xerostomia is a chronic problem in most patients who undergone radiation to the oral cavity. Probably more with the Cobalt machine, less with the linear accelerator, and probably even less with Proton. But some amount of xerostomia will be there. Hyperpigmentation is something which we don't see too often nowadays. But again, it's a temporary phenomenon.
So next question by Dr. Ashish J. Sorry, I have missed. Yeah, Dr. Nitin Das. Can you please tell us the difference between SIB plants and hyperfractionation, and also the importance of SIB plants?
SIB, that is getting highly technical, I would say. I thought it would be more relevant for a radiation oncology PG rather than an ENT. But anyway, SIB actually stands for simultaneous integrated boost. SIB. So, well, I mean, the easiest way that I can probably explain is uh, let us say I'm treating a tumor of the pyriform fossa. So what we do is we give a differential fractionation. So sometimes the core tumor, which we see on the scan, which we draw as GTV, we would go at a slightly higher dose per fraction. We may even prescribe 2.2 gray per day to that small gross tumor volume, while the rest of it we may prescribe at 2 gray, 2 gray. So essentially meaning that as each day you're giving a slightly more radiation dose to the gross tumor. So that is what we call SI boost. Hyperfractionation was, I honestly don't have any experience with hyperfractionation because it is more of a logistical issue in most of our hospitals that we can't treat the same patient twice or thrice in a day on the machine because of our patient load. But hyperfractionation, I mean, the concept is either 2 fractions per day or 3 fractions per day. So you, instead of giving one single 2 gray per day, you could give 1.8 gray twice a day, which means you're delivering about 3.6 gray a day with a 6 or a 7 hour gap. Or you could deliver 1.5 gray into 3 times a day with a gap of about 5 days. See, ultimately, these are all, there's a lot of radio biology which is involved, and you're only trying to escalate the dose as much as possible, because higher the radiation dose you deliver to a tumor, theoretically better is supposed to be the response. So rather than giving 2 gray per day, we assume that 3.6 will work better, or 4.5 given in a day is better. And which is one of the reasons why we do a lot of hypofractionated radiotherapy nowadays on the cyberknife. As I mentioned, for meningiomas, vestibular schwannomas, hypoglossal schwannomas, etc. We deliver fraction sizes as large as 5 gray to 7 gray per day. And, patients are able to complete their treatment in just 3 days or a maximum of 1 week. I hope that answered
Yes.
that question.
So there are a few questions regarding keloid, sir, which you have mentioned. So I'm just going to club the questions. One is what is the dose you give for keloid, and duration and modality after excision?
Yeah, so basically what we do is most of the times we see the patient up front, even before the surgery is done. So we see the keloid. Typically, let us say you have something in the ear, a earlobe keloid, and then we send a message to the plastic surgeon to excise the keloid, and we give very clear instructions to the patient that they have to report to us for radiation in 24 hours post excision. So if a surgery is done, if the excision is done on Monday, they are in my OP on Tuesday, and it's a small scar. It would probably measure just about maybe a centimeter or a couple of centimeters in the earlobe. So we use electrons. So it's a particle radiation coming from a linear accelerator. Unlike X-rays, which penetrate very deeply, electrons have a finite depth. They don't go beyond 1 centimeter or 2 centimeters. So it's highly suitable for treating keloids, because we basically want to treat just the skin and the subcutaneous tissue. And the treatment is just 4 days. So I start the treatment on Tuesday, and Tuesday, Wednesday, Thursday, Friday, 4 sessions, the treatment is over. We deliver 3 gray per day. So it's 3 gray into 4. So total of 12 gray.
Yes, sir. Next.
So it's a simple outpatient treatment. I mean, you just lie down on the machine for about 5 minutes.
Moving on to next question by Dr. Shivkumar. What is the difference between IMRT and VMRT?
It's IMRT or VMAT. Yeah. So, both are basically the same. See, when the principle is IMRT, intensity modulated radiotherapy. Now, what happens is let us say, even if you look at this, even if you look at the proton machine, uh, if a patient is undergoing a conventional IMRT, what happens is the machine goes to different angles. As it moves to a particular angle, it stops, then it shoots a little bit of radiation. Then it moves to another angle, maybe 90 degrees, it stops, it shoots. So the treatment times on the machine are slightly prolonged. It could take about 10 to 12 minutes for the patient to complete one session each day. VMAT, basically what happens is the machine is continuously revolving around the patient and continuously emitting radiation. So you're basically just shortening the treatment time on the machine. Otherwise, the basic underlying principle and concept even of VMAT is actually IMRT. So what happens is in institutions where they have equipment where VMAT is possible, they are able to treat more number of patients on the machine in a day because your treatment times are much less. That's one of the main advantages. Yeah.
Sir. Next question by Dr. Kalpana. What about taste sensation loss post radiotherapy? Is it temporary or permanent, sir?
Well, it is, well, I wouldn't say it is permanent, but taste sensation is something which, especially when we've treated carcinomas of the tongue or floor of the mouth or buccal mucosa, where the tongue invariably gets almost the entire dose of radiation. By the end of the treatment course, patients would have completely lost their taste. So let us say, even if you take one of your favorites, I mean, even if you suppose, even if you poured a couple of teaspoons of payasam or something into your mouth, you will not be able to get any taste. It can be as bad as that. But once you complete the radiation, it takes usually about at least about 2 months for at least 50% of your taste sensation to come back, and a minimum of at least about 6 months for about 75% of your sensation to come back. You have a small percentage of patients who come even a year after completing radiation, saying that some of their taste sensations are not intact, etc. But it's all very subjective. But usually there's a good return of taste sensation in at least 6 months post radiation.
So, one more question. Um, can you give us some? Uh, how long does radiation therapy take in advanced JNA?
In advanced,
JNA, juvenile nasopharyngeal angiofibromas.
no, that's conventional radiation, 6 weeks.
So, yeah.
Of course, we have. I mean, there are some data and there is some evidence to use, hypofractionated radiation also, but it's not something that we very commonly practice. We usually subject the patients to about 54 gray spread over about 27 fractions over about 5 to 6 weeks.
Yeah. Dr. Haider was asking, what are the lines of management for post radiotherapy mucositis?
Well, see, the mucositis generally tends to subside over time. I mean, it really doesn't require any medication as such, though simple mouthwashes actually help. One of the simplest mouthwash that we use is a glass of warm water with a quarter teaspoon of salt and a pinch of baking soda. You gargle you wash your mouth about 3 or 4 times a day. Your mucositis generally tends to subside. There are some pharmaceutical compounds as well. Some of these curcumin containing products which are into the market today, which we are using. We also use green tea decoction as a mouthwash because of its antioxidant properties, tends to reduce the mucositis.
Yes. So, yeah, this is, I think we have concluded all the questions from the chat section. So, I have one question, sir, pertaining to the recent events which you are seeing. There were a lot of post COVID people being treated for radiation. So, can you give us
Yeah.
some idea, info about this, sir?
Well, it makes it. I mean, if it's post COVID, I mean, as long as the patient is fit, otherwise, I don't think it matters at all
Yeah. And
because primarily you're focusing on the head and neck.
okay, sir.
It's a different issue if I was treating a patient with a carcinoma of the lung, where the lung has already been compromised because of COVID. Otherwise, if it's a head and neck patient, I mean, almost every day we are seeing a patient in the OP who says they've recovered from COVID last month or a couple of months ago. So that really doesn't impact treatment at all.
And we also hear some recent studies about radiation being given to active COVID people in the treatment. What is?
Yeah, that's a very interesting question, and I personally don't have experience, but one of my very junior colleagues called, I think her name is Dr. Sashi Priya. There's only one institution, I think, in the entire country, which is an institution which goes by the name of Harsha Mitra.
Trichy.
Very easy for you. I think it's very easy for you to remember. Part of your name as well.
It's in
It
Trichy,
is.
right, sir?
It is called. It is Harsha Mitra in Trichy.
Yeah, that's what I heard it. I was in Trichy when I.
Yeah. So you need a slightly different kind of radiotherapy equipment for that. So they're using a low dose superficial kilovoltage machine to deliver very low dose rate radiation to the lung. I mean, there are a lot of institutions which are practicing it all over the world, but in India, as a pilot study, I think only Harshamitra has started, and probably uh, they may publish their results very soon.
Good to know that, sir. One last question from the delegates. What is there any role of artificial saliva in mucositis?
You don't see mucositis is different compared to xerostomia. So you don't use artificial saliva for mucositis. You use artificial saliva for xerostomia. So we in the US and most Western countries, there are some saliva substitutes which are available in the market. In India, we used to have, but they've all kind of been there for a while. They go out of, but we use what is called mouth sprays. There are brand names like Wet Mouth, etc., where you spray it into the insides of your cheek. You don't spray it on the tongue, but you spray it on the inside of your cheek about 3 or 4 times a day, and it basically simulates saliva. So it basically lubricates your mouth.
Yes. So yeah, so this completes the
Sarika,
interact. Anyone?
hello.
Hello.
Hello. Namaste ji, namaste, क्या हाल है?
Yeah. Sorry, sir. So this completes the question and answer sessions. Thank you, sir, for being a part of our webinar series. We are really happy and proud to be on our to have you host on our platform. You really shared a lot of information for the PNT postgraduates, and I can see a lot of thank you messages in the chat section. Thank you very much, sir, and I wish you a very good night, sir.
Thank you very much. Pleasure being part of this. Thank you.
Thank you, sir.
Good night.